Good evening, guys. I have discussion for you. We're discussing Canada's assisted dying for terminally ill patients. Here we go. A Canadian woman in her 80s, identified only as Mrs. B, had been struggling with significant health complications after coronary artery bypass surgery. Though she initially mentioned the idea of medical aid in dying or maid to her family, she clearly withdrew that request. When formally assessed the next day, citing her religious beliefs, her personal values, and her desire for palliative or hospice based comfort care instead. Despite this, her husband described in the report as suffering from severe caregiver burnout, pushed for a second urgent maid assessments. Within hours of that request, Mrs. B was approved and died by maid, even though she had recently and explicitly stated she wanted palliative care. A provincial review committee is now examining the case, raising concerns about whether coercion, undue influence, or systematic gaps contributed to her death. What MAID means in this context: Canada's medical assistance in dying law, in effect since 2016, allows eligible adults with serious and incurable conditions to choose a medically assisted death. The law requires that the decision be voluntary, informed, and free from external pressure. The article situates Mrs. B's case within this legal framework, emphasizing that MAID is meant to be a patient driven choice, not something initiated or accelerated by family members or caregivers. Timeline and key facts. The committee flagged. The review committee's concerns stem from a sequence of events that unfolded with unusual speed: health decline and palliative care requests. After surgery, complications, and functional decline, Mrs. B was discharged home. Palliative care supports mentioned in mention of MAID. She brought up MAID to her family and her husband immediately contacted a referral service withdraw of MAID requests. At the first assessment, the next day, she revoked the request, saying MAID conflicted with her beliefs and that she preferred palliative sedation or hospice care. Returned to hospital the following day. Her husband brought her to the hospital. Clinicians found her medically stable, but noted his caregiver burnout. Urgent second assessment. Her husband requested an urgent assessment. Hours later, she was approved and died by MAID. The committee highlighted the rapid turnarounds, the contradiction between her stated wishes and the final outcome, and the husband's emotional exhaustion. The red flag as a red flag, as red flags. Why the case is concerning and what the review is examining. The central issue is whether Mrs. B's death truly reflected her own autonomous choice. The committee is scrutinizing possible coercion or undue influence, especially given her husband's burnout and his role in initiating both assessments. The appropriateness of same day or next day assessments, which may not allow enough time to confirm volunteerness or explore alternatives. Whether clinicians had enough opportunity to evaluate her mental state, preferences, and consistency of wishes after her change of mind. The case explores how caregiver stress, family dynamics, and systematic pressures can collide in ways that jeopardize patient autonomy, practical implications, and what to watch for next. The case may influence future MAID policy and clinical practice in several ways. Stricter safeguards around rapid assessments, especially when a patient has recently expressed ambivalence to reverse a decision. More robust screening for caregiver burnout, recognizing it as a potential source of unintentional pressure. Clear documentation requirements with when a patient withdraws a made request, ensuring that reversal is treated as a serious clinical signal, not a temporary hesitation. Potentially cooling off periods when concerns about coercion the review committee's findings could shape national conversations about how to balance compassionate access to MAID with the need to protect vulnerable patients. Takeaway: the article uses Mrs. B's story to illuminate deeper tension within MAID practice. How do we safeguard autonomy when illness, family strain, and caregiver exhaustion intersect? Her case raises profound ethical questions about volunteerness, the limits of caregiver involvement, and whether current safeguards are strong enough to prevent rushed or extremely influenced decisions. The ongoing review signals that policymakers and clinicians they need to rethink how MAID assessments are timed, monitored, and protected, especially when a patient's stated wishes shift in the final days of life.